Hi everybody, welcome once again to the Big Ideas Theater. I'm your host Ed Highland, and we're here talking with Courtney Rowan, Dr. Courtney Rowan, talking a little bit about strategies for the immunocompromised patient and respiratory failure, and obviously something of great interest for respiratory therapists. How is respiratory failure perhaps different from immunocompromised, in the immunocompromised, different from, say, the general, if you will?
Yeah, so I think one of the things that makes this population unique is that they are at a very, very high risk to develop ARDS. And almost exclusively their respiratory failure is oxygenation failure and not hypercarbic respiratory failure. So our approaches to mechanical ventilation and respiratory therapies are often different because of that risk.
Is there an opportunity to perhaps change the outcomes early in the course of respiratory failure?
I do think that this population offers a unique opportunity for that, especially in pediatrics. Most of the patients are already in the hospital at the time the respiratory failure develops, so I think that that leads a natural opportunity for both early identification and potential early interventions.
What is the utility, if you will, of non-conventional approaches in dealing with this?
Yeah, so I think anytime we talk about ARDS, especially in the pediatric population, we always discuss non-conventional mechanical ventilation like the oscillator. And I think the jury's still out in that, but I do believe that we have some occurring evidence that's coming up right now that shows us that maybe if you're going to use this, you should use this really early in the course of ARDS.
And as I understand it, there's been some changes fairly recently, further discussions on dealing with pediatric patients as opposed to adult patients as well, and maybe even some new guidelines that will help you out.
Right, you know, they have recently, in the past probably year, 1 to 2 years, they've redefined ARDS for pediatric patients, and this obviously is spilling over into the immunocompromised. And in the guidelines, they talk about mechanical ventilation strategies, and there is a consideration for moving to high frequency oscillatory ventilation when you have certain pressures on the conventional ventilator. In the adults, they've sort of nailed in the coffin the use of oscillators anymore, but it hasn't gone completely out of favor in pediatrics. And I think this population, because of the severity of the lung disease, it always comes up if we should be using it.
And if you don't mind me going a little off script, one of our earlier interviews was talking a little bit about mechanical ventilation and how there seems to be some research coming out and perhaps a different approach and thought to how long a patient should perhaps be on mechanical ventilation. Does that apply also, those thoughts and research, to immunocompromised?
I do think that applies, and we know that, so we had a study published from a multi-center cohort about 1.5 years ago, and it looked at the 2-week mark for these patients seems to be the place where their mortality really skyrockets. So after the first 2 weeks, the mortality is sort of the same, but once you break that 2-week mark of mechanical ventilation, then your mortality just shoots up. And then from a non-conventional standpoint, I just had a paper accepted in respiratory care that shows us with the oscillator that if you're put on the oscillator after a week of mechanical ventilation, no one survives in the stem cell transplant population.
Wow, good information to know. Dr. Courtney Rowan, thank you so much for joining us.
All right, thank you.
And this is the Big Ideas Theater, sponsored by Draeger.